All right, thank you so much for that introduction. I can't see the chat, so if you have any questions, just unmute, please. I'm really excited to talk with you today. And I want to admit that, yes, I am a new faculty, and so this presentation is really very data light. I have lots of data that I could show, but I really wanted to give a broader overview about who I am, what I study, and just really excited to be here. So we'll get started. The title of my presentation is Integrating Pain and Movement Science to Advance Clinical Practice, and hopefully that title makes sense after you hear a little bit more about what I do. So I'll start by talking a little bit about who I am. So I started my training at the University of Florida. I guess I should say I did my undergrad at Southern Illinois University, but then went to University of Florida to do my clinical training in physical therapy. And then I worked for a few years as a physical therapist. I worked in acute care and in inpatient rehab. So mostly working with patients who had a lot of diverse backgrounds and diverse diagnoses. So many of these patients had medically complex issues, or when I was in inpatient rehab, I worked with a lot of patients who had spinal cord injuries and strokes or traumatic brain injuries. So I kind of caught the research bug back in undergrad. So when I was working as a PT, I decided to go back and get my PhD in rehab science. I did a postdoc then at University of Colorado, and now I am here as an assistant professor at University of Delaware. So like I said, my experience and my clinical background is in physical therapy, and that really informs my practice. In working with all these diverse patients and populations, I really found that the most consistent thing across all of these patients was the impact of their pain and how that negatively impacted their mobility. And I really found that I didn't know how to best motivate and educate my patients on how to control their pain and how to continue to move and participate in their daily life and in the face of that pain experience. I wasn't sure how to provide treatment that was both alleviating pain and improving function at the same time. And as I was becoming more and more challenged by this as a clinician, it was also becoming more evident in the general healthcare community and across the general public that pain is a growing public health problem. So as many of you know, there may or may not know, but probably you're at least a little bit aware that there's been a strong emphasis placed on clinical pain research because of the rising healthcare costs and health consequences associated with pain conditions. And I want to bring up this model. This is one of our earliest conceptualizations of pain. And in this model, you'll see that fire acts as the stimulus, and the signal travels up the nervous system into the brain where it's perceived as pain. And for many years, we have based a lot of our assessments and our interventions on this very simplified model. But really, we know now from a lot of research and evidence that pain is more complex and disabling, and it's even now not just a symptom of other diseases, but is often viewed as a nervous system disease itself. And while we know that pain conditions are some of the leading causes of disability around the world, we really have a poor understanding of how pain impacts movement and sets up the risk for long-term disability. We know that pain leads to disability, but we don't quite know how that happens and what those interactions between pain and movement are. So to address this gap in evidence, I've worked with my group of collaborators to develop a model for integrating pain with movement. And in this model, we show how multiple pain factors that you can see here on the left interact to influence movement and function. Movement and function and changes in those components feed back into the system and can further alter pain processing within the nervous system. And over time, these changes ultimately are going to impact recovery. So this is a really, like I said, data light presentation, but this is sort of the conceptual framework that I come from. and that I base a lot of my work on. And I've conducted with my collaborators and colleagues several studies to test the different relationships within this model. And really the overall goal is to use this model to study pain conditions from a nervous system disease perspective. So how do we do that? What types of measures do we maybe use when we're thinking about these different factors? So the primary factors in this conceptual model, and there's lots of factors that impact pain, but these are the ones that I focus on. So we have sensory factors. So there's mechanisms and measures that we can use to establish pain sensitivity using what you see on the left is a heat and cold probe, so you can measure cold and heat sensitivity to pain. And then another way to measure it is in conditioned pain modulation. So we have these models or these tools to probe the nervous system and understand more about sensory factors. We also have self-report tools that we can use to understand more about psychological factors. So something like the OSPRO yellow flag screening tool is a measure that globally looks at different aspects of pain-related psychological function, so we can get an idea of what a patient's positive affect or coping or negative coping is. And then we also probe the nervous system by using things like EMG. So looking at how trunk muscle activation, for example, in patients with low back pain, looks for when patients are walking or bending forward. So I'll give you an idea of just one study that we did to look at pain from a nervous system disease perspective using this model. So we used sensory, psychological, and motor tools that I mentioned on the previous slide to identify low back pain subgroups. So we had individuals with low back pain come into the lab. We tested all these factors, and we used a cluster analysis to split these groups, the sample of low back pain individuals, into smaller groups who had maybe more similar or different nervous systems. And then we validated these subgroups. So we decided we wanted to look at these subgroups and see if we have these two subgroups, are they clinically meaningful? Do they show differences in their function and their movement, or maybe their clinical outcomes such as disability? So in this study, again, brief overview, we tested their nervous system and we found two distinct groups in our sample of 70 individuals with low back pain. We had a group that had showed more favorable responses across the nervous system, and then we found a group that had less favorable nervous system responses. We termed these our adaptive subgroup and our maladaptive subgroup. And then, like I said, although we were able to identify these groups, we wanted to see if they were clinically meaningful. So we then tested their walking performance using established clinical measures that physical therapists often use. And then we also assessed their pain and disability using self-report measures of pain interference with daily activities, as well as an established measure of disability. And very briefly, what we found was that indeed our maladaptive group, that group that had less favorable responses to nervous system responses, so higher pain sensitivity, higher psychological distress, and more atypical nervous system motor activation in their back, they also showed worse walking function, slower speeds in completing those walking tasks, slower obstacle negotiation, and then they also had worse clinical presentation. So they had higher pain interference, and higher disability. So what this showed us is that we really needed to look at these sensory, psychological, and motor factors to really understand and understand this relationship with function. There was a collective contribution of all of these factors to worse functional outcomes. And this highlights that important intersection between pain and movement and really gives us an idea of how we could continue to look at these different factors that may drive the development of poor movement or movement impairments, poor function, and maybe disability in the long term. What we don't know from this work is whether these types of subgroups or these types of measures can predict outcomes, because this was a cross-sectional study. And we still don't know what the best treatment is to target some of these factors to improve outcomes. So my next step, actually right now I'm working on a grant that's going to extend this subgrouping work and really look at more of a longitudinal investigation so that we can potentially establish the predictive validity of these subgroups and really continue to build an evidence for studying and treating pain as a nervous system disease. I know I'm really close on, I'm really over time a little bit, so I'll just end with kind of big picture research program objective is to conduct high impact clinical pain research to optimize health and functional outcomes for people with chronic pain and disability. And some of the ways that I'm hoping to do this are to continue to use that model to understand the neural mechanisms of pain and movement, as well as integrate functional assessments into pain care, and then develop and translate movement-based interventions for pain. These are all my collaborators and colleagues, as well as funding sources. And, well, I should say these aren't my funding sources anymore, but they've supported my work thus far. And thank you so much. If you have any questions or interested more in my work or collaborating, please reach out.